lecture. This should probably take about maybe 45 minutes to an hour to go through. These are your student learning outcomes. I'll let you read these on your own time. And your concept definition. So metabolism refers to the sum of all physical and chemical processes by which living organisms are produced and maintained. So metabolism is a lot of biochemical reactions that occur in the body's cells, and it helps to produce energy, helps to repair cells in your body, and helps to maintain life and keep people alive and all your body systems functioning adequately. So the metabolism is really controlled by the release of many different hormones. The hormones act as little messengers that, travel to their targeted organs or glands and help them to function adequately. So the main switchboard, as it is sometimes called, or sort of the gland organ that is in control of the production and release of different hormones in the body, would be your hypothalamus. So you may know the hypothalamus is up in your brain, and it sits just above the brainstem. And what it does is secretes regulatory hormones. So these hormones that it secretes will travel down to the pituitary gland. And the pituitary gland is considered like your master gland. It's kind of like the gland that then sends out all the signals to other glands in the body once it receives its message from the hypothalamus. So your pituitary gland has two parts, has an anterior and posterior. All right, so posterior pituitary does not actually, create any of its hormones that it releases. It already has hormones that are, sort of given to it from the hypothalamus, and they sit there in the pituitary, posterior pituitary until they're, signaled to be released. And the anterior pituitary is able to receive signals from the hypothalamus and then work on creating those hormones that are needed, and then they will secrete them and send them off to wherever they need to go. So the main point of me describing all of this is just to sort of help you understand that the hypothalamus is kind of in charge of all of the hormone regulation and production. It can receive feedback from different endocrine glands in the body, and if it recognizes that there are low levels or high levels of different hormones, then it will then signal the pituitary gland to either hold back from making further hormones or to continue making more hormones if there are not enough. All right, so the hypothalamus is like your switchboard. It kind of controls everything and tells the pituitary when to release hormones or when to stop releasing hormones for the rest of the body. In the scope of the concept, you have underactive, which would mean that your metabolism is slow or not working adequately. It's not producing, the amount of hormones that your body needs, or it's not able to keep up with the demands the metabolic demands of the body, things are kind of slowed down in underactive metabolism. All right, so for this exemplar, that would be our hypothyroidism. Okay, so hypothyroidism, everything is slow. Then you have normal metabolism. So in this instance with our exemplar of thyroid disease, this would be like your euthyroid, meaning that your thyroid hormones and your thyroid levels, everything is balanced, everything is working together well, it's keeping up with the metabolic demands of the body, and it can keep up with the various demands that are on the body, and basically things are just working as they should be. And then your overactive metabolism. This is when everything is working too hard or making too much hormone or accelerating or increasing your metabolism. So overactive, think of it as working harder than it needs to be, okay? So with this exemplar, that would be your hyperthyroidism. So your thyroid is working harder than it needs to. It's producing too many hormones. It's working sort of accelerated or faster than it needs to. There are different risk factors for alterations in metabolism. Genetics being one of them, that is a big risk factor. If you have family history of, autoimmune diseases or, different endocrine diseases like diabetes or thyroid disease, anything like that. So family history will kind of predispose you to having the risk of developing metabolism disorders in yourself. So as your body ages, your metabolism slows down. Your age, when you're younger, your body can usually adjust pretty well to the different demands, metabolic demands, and you can accommodate, fluctuations in your metabolism. Your body's able to sort of keep up with the changes. But as you get older, everything starts to slow down and the body has a harder time keeping up with the metabolic demands. Your hormones can play a role. So think of how I was just talking about the hypothalamus and the pituitary gland and how they work together to secrete hormones when the body needs them. And if there is some sort of congenital defect, or maybe someone develops a tumor, a primary problem in these areas, then that will affect the secretion of different hormones. Your body temperature. So think of when someone has a fever, for instance, when their body temperature is elevated. What do you notice with their vital signs? Well, their heart rate is typically going much faster, right? Because the body is trying to keep up with the metabolic demands that are occurring. So when you have a higher body temperature, you're having a higher metabolic rate, okay? So your body tries to compensate and keep up with that higher metabolic rate. If you have a low or subnormal body temperature, everything slows down. So your metabolism slows down. And it's quite evident when, you have a patient who is hypothermic. For instance, when I care for patients in the intensive care unit who are receiving hypothermic protocol, meaning that we keep their bodies cold, purposely after a sudden cardiac arrest to try to preserve brain function. And when we do this, we have them on like a cooling blanket. We try to keep their body temperature around 33 degrees Celsius, which is quite cold. And once you see their body temperature drop and reach that targeted goal of the 33 degrees Celsius, you notice that their vital signs oftentimes change. Their heart rate becomes slower. Their urine output may not be as adequate. You can just kind of see all the different organ systems within the body slowing down because of the cold body temperature. So your metabolism slows down. Exercise increases your metabolism. When you sleep, it slows down your metabolism. Nutritional status, so if somebody is malnourished, they are going to have an abnormal metabolism. We'll talk a little bit about that with hyperthyroidism and the way that their body, their metabolism is just going so fast and working so hard that their nutritional status actually ends up being depleted just because of how hard that metabolism was working. Decreased liver function. So think of all the different roles of the liver, how it is supposed to absorb and secrete different sort of what's the word I'm looking for? I completely lost my train of thought. Sorry about that. When your liver is sort of like supposed to metabolize like medications and excrete like the toxins and the waste, then if you have decreased liver function, for instance, maybe in someone who abuses alcohol, which you guys just recently learned about, your liver's not able to work so well anymore, right? It cannot metabolize different medications or nutrients that it's supposed to, and that results in an abnormal metabolism. Think of its effects on the body. Inadequate perfusion of oxygenated blood. So patients with cardiac disease or pulmonary disease, when their body is having to compensate for abnormal, say, perfusion, think of what the body does. The heart rate will increase, right? The blood pressure initially will increase. The body tries to compensate for the abnormal perfusion, and that increases the metabolic demand on the body. The body has to keep up with that. So when there's inadequate perfusion, the body has to compensate and increase its metabolic demand to keep up with sort of those compensatory mechanisms. So in thyroid disease, we are talking about a large gland that sits in the anterior part of the neck. So it's anterior to the trachea. So you see this little picture here, this gland that almost looks like a saddle, or sometimes people call it like a butterfly shaped. It sits anterior to the trachea, meaning in front of the trachea, and it is below the larynx. Okay, so it's inferior to the larynx. So this thyroid gland is very, very vascular. It actually has about 5 times the blood flow to it than the liver does, and we know that the liver is very vascular too. So just wanted to mention that because that comes into play and becomes important when patients are having surgery on their thyroid, because it's a very vascular gland, so high risk for bleeding when it is manipulated. So the thyroid gland is closely linked with the nervous system, the immune system. It regulates functions of many organ systems, and it plays a vital role in cellular interactions, patients' metabolism, their growth. So it's a pretty important gland. And when this gland becomes abnormal or has an alteration in its function, we will see all of the effects that it has on the body, which we're going to discuss in just a moment with hypothyroidism and hyperthyroidism. So there are 3 different hormones that the thyroid gland produce. So we have our T3 and our T4 hormones, which are amino acids. And T3 is a stronger hormone than T4. It is less in quantity than T4. We have more T4 that circulates in our blood than we do T3, but T3 is the stronger hormone. These hormones are solely responsible for the metabolism in the body. So they help to increase one's metabolism. And the way that thyroid hormones are released or secreted by the thyroid gland is by something called the thyroid stimulating hormone. So your TSH. Okay, so your thyroid stimulating hormone is a hormone that is released from the pituitary gland, and that hormone will travel to the thyroid and connect, to the receptors on the thyroid and say, you need to produce more T3 and T4. So it is dependent on the thyroid stimulating hormone. Okay, T3 and T4 are necessary for brain development and necessary for normal growth. So a lot of times when, women are pregnant, they will want to be sure that their thyroid levels are adequate because it's important for the brain development of the fetus. Okay? So calcitonin is another hormone that is released by the thyroid, and it is released in response to high levels of calcium in the plasma. So this hormone helps to decrease calcium in the blood. All right. So it helps to reabsorb calcium into the kidneys and decrease the reabsorption of activity of osteoclasts in the bones. So it increases its disposition in the bone. So basically its role of calcitonin is to decrease the level of calcium in the blood. So your screening. So for lab tests that you can do, blood work for thyroid disease, a lot of times the TSH, or thyroid stimulating hormone, is used to sort of measure whether or not someone may have an alteration in their thyroid gland. So you can see here the American Thyroid Association recommends screening begin at age 35 years of age and every 5 years thereafter. And that's because the alteration in your thyroid or risk for thyroid disease tends to be more common in your middle-aged to older adults. More specifically, higher risk would be women. So serum TSH, I do want you to know the normal levels, okay? So 0.4 to 4.2 for TSH is something that you should know. And your serum free T4 and your T3, total T3, are also used to sort of measure whether or not your thyroid is producing enough hormones as it should, or if it's, producing too much hormone, then you're going to see elevated T4s and T3s. Okay, so those I don't really want you to know the details about. Like, you don't have to know the ranges for the free T4, T3, and so on and so forth. The main one that I want you to be familiar with is the TSH level. So you can highlight or star that one in your notes. That's the main one that's important, because that will be what is most commonly used to assess whether or not someone has an abnormality with their thyroid function. Okay, So people can also have tests that are called the T3 resin uptake. So this is to assess patients if they have basically like absorbed iodine into their thyroid, because iodine is essential for the thyroid to produce T3 and T4. So patients will sometimes be given iodine via like a pill, and they take that, and then they'll have scans on their thyroid that they can look to see if their thyroid gland has reabsorbed or absorbed the iodine from that pill, or if there's problems with the absorption of iodine, or if the iodine was absorbed and it's causing an excessive amount of thyroid hormone production from the thyroid. Okay, so just keep that in mind, that iodine is essential for the functioning of the thyroid gland and its production of T3 and T4. Then there are also thyroid antibodies that can be measured. So your thyroid antibodies will basically let you know if there is like inflammation or possibly autoimmune diseases that are affecting the thyroid. So when your antibodies are elevated, then you're going to be thinking that, the patient may have an autoimmune disorder of the thyroid gland. So your diagnostic evaluators. So I just kind of talked about your radioactive iodine uptake. So that's when you give somebody iodine that they ingest, like in a pill, and then you can monitor their thyroid. You can check it with the gamma probe to measure how much radioactivity was absorbed into the thyroid gland, and then you can look at their T3 resin uptake as well. Fine needle biopsy. This can be used when patients have nodules on their thyroid. So sometimes nodules will end up causing an abnormality in the thyroid function. And the only way to figure out if those nodules are cancerous or not, you would do your fine needle biopsy. So that will detect whether or not nodules on the thyroid are malignant or cancerous. Then you can also do thyroid scans, radioscan, or CT scans. And these are used to assess whether or not the thyroid may be overactive or underactive. So you can see this little picture here down in the right-hand corner. It's sort of all like colorful, and you can see that little red area that the arrow is pointing to in the picture. That's an overactive area of the thyroid. So it will kind of highlight whether areas are overactive or underactive on these scans. So when we are evaluating our patients and doing all of our diagnostic testing, we want to assess a few things. So you want to know if your patient is allergic to iodine. So remember asking about like shellfish allergies. That could signify that they have allergies to iodine. Because remember what I spoke about on the last couple slides is some of the testing that we do is administering radioactive iodine to patients via a pill that they ingest, and we look for its effect on the thyroid gland. So we want to know if they have allergies to iodine or shellfish. There are also other medications that can affect the production of thyroid hormone. Okay, so there are a bunch of them listed here down below. So you do not have to know every single one of them, but I will mention a few that I do want you to know. So one of them, amiodarone. So amiodarone contains iodine. Okay, when patients are on high doses of amiodarone, this can affect their thyroid, because remember, iodine is essential for the thyroid to produce thyroid hormones, the T3 and T4. So if you're administering high doses of amiodarone over a long period of time, that has a higher amount of iodine in it. So if patients are receiving a lot of iodine, what effect is that going to have on the T3 and T4? Well, it's going to cause it to produce more T3 and T4. Remember, because the iodine helps the thyroid to produce those hormones. So if you're taking iodine in a pill that, such as amiodarone, and you have high doses, you've been taking it for a long time, that's going to stimulate the thyroid to keep making more thyroid hormone. So it's going to increase your T3 and T4 hormones. Aspirin can also increase the thyroid hormones, okay, T3 and T4. And then there are some medications that can cause sort of a decrease or inhibit the thyroid hormone production. And those are ones like lithium, phenytoin, and propranolol. So those three at the bottom, lithium, phenytoin or dilantin, and propranolol, those can decrease the T3 and T4 counts. So those are the only medications I really want you to be familiar with. So jumping into the variations of thyroid disease. So hypothyroidism, or sometimes called myxedema, and it's called myxedema because in hypothyroidism, patients have like a swelling in the connective tissues throughout the body. So that's why they call it myxedema. But it means the same thing. Hypothyroidism, myxedema are the same thing. So this is when patients have suboptimal or low levels of thyroid hormone. So their thyroid gland is not producing enough thyroid hormone. Okay? So in thyroid disease with hypothyroidism, what you're going to see when you draw their labs and you look at their blood work, their TSH, or their thyroid stimulating hormone, remember that's the one released from the pituitary gland, the TSH level is going to be elevated. Okay, so write that down. Your TSH level is going to be elevated. And your T3, T4 will either be, on the lower normal side or low. So that's your TSH is elevated, and your T3 and T4 are going to be either on the low side of normal or low. And why is that? Well, in hypothyroidism, you have low levels of thyroid hormone. So that's low levels of T3, T4. Okay? So if you have low levels of T3 and T4 circulating in your blood, circulating in your bloodstream, and that hypothalamus up in your brain is looking for feedback from its organs and its endocrine glands, it looks to see that there are adequate amounts of hormones circulating in the blood, okay? If it recognizes that there are low levels of thyroid hormones circulating in the blood, it's going to say, uh-oh, we don't have enough thyroid hormone. We need to produce more thyroid hormone. And it will signal the pituitary gland to create and release more TSH, the thyroid stimulating hormone. Because it's saying, oh no, we don't have enough thyroid hormone circulating in this blood. Pituitary gland, release more TSH. That TSH has to go to the thyroid gland and stimulate the thyroid to make more thyroid hormone. So that's why we end up with higher levels of TSH in hypothyroidism. So higher levels of TSH in hypothyroidism is caused because the hypothalamus can realize that there are low levels of thyroid hormone, T3, T4, circulating in the blood. So it keeps signaling the pituitary, make more TSH, we need more thyroid hormone. Make more TSH, we need more thyroid hormone. So I hope that makes sense. It's a little bit confusing, but if you really take a minute to really help yourself understand that concept, it will make much more sense. So hypothyroidism, you have a high level of TSH and lower levels of the thyroid hormones, T3 and T4. Okay? So it occurs more frequently in older women, so it can be middle-aged to older women, and there are many different causes. So we see the causes listed here. So autoimmune diseases such as Hashimoto's thyroiditis. So that is when basically the thyroid gland kind of attacks itself. So Hashimoto's, the thyroid gland is attacking itself, and it's causing the thyroid to not produce as much thyroid hormone as it should be. And because of this, the thyroid keeps trying to work a little bit harder to make the thyroid hormone, and it will become enlarged. So with Hashimoto's thyroiditis, patients will oftentimes have an enlarged thyroid gland, and this is also called a goiter. Okay, so Goiter, a goiter. That just simply means the thyroid gland is enlarged. Excuse me. Also, another autoimmune disease is Graves' disease. And with Graves' disease, this is actually a form of hyperthyroidism. All right. So patients who have Graves' disease or hyperthyroidism, their thyroid is overworking. It's working really, really, really hard to keep up with the metabolic demand, and it keeps producing too much hormone. So what ends up happening over time is the thyroid burns out, okay? So it's either going to burn out because of its overproduction, or the patient may be treated for Graves' disease with medications, and that's going to cause the thyroid to burn out. And then you end up with hypothyroidism because the thyroid's kind of burnt out over time, it's worn out, it can't keep up with the process anymore, so it kind of gives up and can't function at that high rate any longer. So they end up hypothyroid after that. So that's why it says post-Graves' disease. All right. Atrophy of the thyroid gland with aging. So that's the process that can occur where the thyroid gland sort of shrinks over time. You just don't produce enough thyroid hormone if it is atrophied. The therapy for hyperthyroidism, I talked a little bit about a second ago when I described the Graves' disease. If patients are being treated for hyperthyroidism, those treatment medications are very strong and can cause the thyroid to burn out over time. Different medications. So remember when I mentioned those medications earlier that I wanted you to be familiar with that decrease the thyroid hormone. So that's your lithium, your phenytoin or dilantin, and propranolol. Radiation to the head and neck. So think of what radiation does to all the cells in the area that is being treated. It basically kills off those cells. So when you have radiation to the head and neck, your thyroid gland is right there, and it's, at very high risk to be affected by the radiation. So if that occurs, then some of the cells, may be damaged. They may not be able to function adequately to keep up with the production of thyroid hormone. Infiltrative diseases of the thyroid, so that's, diseases that may cause scar tissue to form on the thyroid gland. That would be the same idea as the radiation. It's damaging the healthy cells in the thyroid, so therefore the thyroid's unable to produce adequate thyroid hormone. And then the bottom line there can be a little bit confusing. So iodine deficiency and iodine excess. And why is that? Well, iodine deficiency. Remember, iodine is essential for the production of T3 and T4 from the thyroid. So iodine deficiencies aren't so common in the United States because we have, our soil may have iodine in it where we grow our crops and everything, so we're getting iodine through our produce that we are eating. We have iodized salt that we have in our diets. So we have ways of getting iodine into our system. But there are areas in the world where their soil may be deficient in iodine, so they are not eating as much iodine in their diets as we would in the United States. So when this occurs, they become iodine deficient, and therefore, when they don't have enough iodine in their body that can be absorbed by the thyroid to help produce T3 and T4, they end up with lower levels of T3 and T4 production. So that's why iodine deficiency has that effect. And then iodine excess. So if you have excess amount of iodine that is being absorbed by the thyroid gland, that's going to cause a higher production of T3, T4. So your higher production of T3, T4 is your hyperthyroidism, right? So over time, what happens to the thyroid with hyperthyroidism? It burns out. It doesn't work adequately. So over time, this iodine excess that's been causing this hypersecretion of T3 and T4 will affect the thyroid that it burns out over time or slows down, stops working as well over time, and the patient will end up hypothyroid after that. So that's why both iodine deficiency and excess could lead to hypothyroidism. So there are different clinical manifestations of hypothyroidism. Many of them are listed here. Extreme fatigue is common. Brittle hair, brittle nails, very dry hair, a hoarse voice, alopecia, meaning losing hair, sensitivity to cold. Oftentimes these patients are very cold, or sensitive to like sudden cold changes in the air. Then your more severe clinical manifestations, so say this is someone who doesn't want treatment or doesn't comply with their medications as they should, and they become more severe with their hypothyroidism, they're going to end up with more severe clinical manifestations that affect the whole body systems. So subnormal body temperature, so their body temperature is low. That has an effect on the heart where they become bradycardic. They can have thickened skin, a weight gain over time, irritability, and also personality changes. And if this is untreated or, unrecognized, and patients, live with hypothyroidism and, don't take care of it, it can lead to some severe, cardiac disease and also cause death. So untreated hypothyroidism is, life-threatening. Speaking of life-threatening, the big complication of hypothyroidism is something called myxedema coma. So myxedema coma is basically when the body really shuts down in a way. Everything just completely slows down. Because in hypothyroidism, so that's your underactive metabolism, everything's already slow, right? So in myxedema coma, it's basically like your most severe form of hypothyroidism. So it can be caused by different triggers. So that could be like prolonged exposure to cold temperatures, because remember, these patients are very sensitive to the cold. So prolonged exposure to cold temperatures, this is more common in the winter months. So that would be a trigger. Things like infection, major injuries or insults to the body, maybe like a trauma or something along those lines, can all be triggers for myxedema coma. And what you will notice with myxedema coma is basically the whole body kind of shuts down and stops working adequately. So they will become bradycardic, they will be hypothermic, meaning low body temperatures. They will have a change in their mental status. They might be more lethargic or drowsy, and they can also have some changes in their electrolytes. So they can become hyponatremic, also hypoglycemic. And if this is untreated, they can, go into a coma and have some pretty severe effects on their cardiovascular status, meaning like the bradycardia, they'll become hypotensive, and basically their heart can't function adequately and provide adequate perfusion to the rest of the body. So that is why it is life-threatening. So when patients have myxedema coma, the treatment that you want to think of is treating the precipitating factor. So what caused them to go into this myxedema coma? All right, you want to treat that and try to eliminate whatever trigger has caused them to go into this myxedema coma. You also want to be sure that you maintain a patent airway. So remember, if these patients are drowsy or lethargic, they have a change in mental status, they're at risk for airway compromise. So maintain a patent airway. You want to watch their vital signs closely because of their risk for bradycardia and inadequate tissue perfusion. Also their electrolytes. So I mentioned the hyponatremia and hypoglycemia, so monitoring their blood work. You also want to increase their body temperature because these patients are cold. Their body temperature is low. So they may be on like a warming blanket, or you may put multiple blankets on them to keep their body warm, help bring their body temperature up into normal range. And you want to give them thyroid hormones, right? Because myxedema is caused by low amounts of thyroid hormone. So what you want to do is increase their thyroid hormone levels. And this can be done by giving them, pill form of thyroid hormone, or if it's severe enough where they're, in a coma or not able to take PO medication, the levothyroxine, or your T4, that's the medication, can be given IV as well. So sometimes if they're unstable or unwell, they can get their thyroid hormone replacement through IV. All right. So it's very important just to remember that myxedema coma is life-threatening. The whole body kind of like shuts down, slows down, and does not work adequately. Therefore, there is decreased perfusion to all the organ systems, and it can result in death. Okay. Picture to help people who are visual remember your clinical manifestations for hypothyroidism. And your treatment and nursing implications. So, pharmacological treatment would be your thyroid hormone replacement. So, levothyroxine is T4, and that is the most common thyroid hormone replacement that is given to these patients. It's also called Synthroid or levothyroid. All right. So levothyroxine, there are a few important things that you need to know as a nurse caring for these patients. So patient education. When these patients are prescribed levothyroxine, it should be educated to them that they take this medication at the same time every day. And it's oftentimes recommended that they take it in the morning because it can cause insomnia. So preferably in the morning, and they need to have an empty stomach. All right, so they recommend at least 30 minutes prior to meals with a full glass of water. All right, so I'll repeat that again. Same time every day, preferably in the morning because it can cause insomnia, on an empty stomach at least 30 minutes before a meal with a full glass of water. And the reason we say this is because if someone were to eat, within the 30 minutes or shortly after taking their thyroid hormone replacement, it's not going to absorb well. All right. So it's even recommended if patients also take like multivitamins or they're going to have any sort of intake of calcium that they wait 4 hours before ingesting any of that because it will result in inadequate absorption of their thyroid hormone. So it is important to stress the empty stomach and with a full glass of water. And the reason it's a full glass of water and not just a quick, sip of water like some patients can do with their pills is because it can cause some esophageal issues. So you want to be sure that you drink it with a full glass of water to be sure that it makes it all the way down into the stomach and doesn't get caught in somebody's esophagus and sit there because it can cause some esophageal issues as well. So those are really important things to educate your patients about. And then signs and symptoms of overdose. So maybe their dose is too high. So how would you know if their dose is too high? Well, they're going to present like hyperthyroid patients. So they're going to have some palpitations, insomnia, increased appetite, maybe some tremors. So basically their metabolism is going to be accelerated and hyper, like in hyperthyroidism. So the patient should also be aware of those sort of overdose or, too much hormone replacement signs and symptoms. And with elderly patients, it's also important to remember that they have, decreased renal clearance, meaning they don't excrete medications as easily. It's harder for them to metabolize, etc. So when we start patients that are elderly on thyroid hormone replacements, we usually start them on a lower dose to make sure that they can tolerate it and they're not going to become, I don't want to really use the word toxic, but, overdose on their medications because of their decreased renal clearance. So we usually start lower dose and increase their dose slowly to achieve the desired effects. So another thing that could possibly be done for treatment of hypothyroidism is if patients, remember when I talked about the Hashimoto's autoimmune disease, when your thyroid can enlarge or become what we call a goiter? If the goiter becomes so big that it affects the patient's airway, then they may have to have, surgical removal of part of the thyroid gland. And that would only be in the instance where the goiter is so large that it's affecting the patient's airway, is that surgical treatment would come into play. So nursing care. So what's important for hypothyroidism patients? So warm environment, because remember they're intolerant to cold. Their diet should be high protein, low calorie, small, frequent meals. Increase their fiber intake and their fluid intake because they have issues with constipation. Administer sedatives with caution because patients with hypothyroidism, their body metabolizes everything very slowly. Their metabolism is slow. So if you give them these heavy-duty sedatives or pain medications like your morphine, Dilaudid, they're at higher risk for things like myxedema coma to happen because it's going to suppress their metabolism more than their body can handle because their body is already slow and not adequately keeping up with the metabolic demands. So sedatives should be given with caution. Provide frequent rest periods, pace activities because they fatigue easily, daily weights because of their weight gain, monitor for signs and symptoms of levothyroxine overdose, so that would be your palpitations, increased appetite, tremors, insomnia, your hyperthyroid, signs and symptoms, and educate about causes of myxedema coma. And remember, the myxedema coma can be caused by different triggers. All right, so that's like your prolonged exposure to cold, your trauma, some sort of like big insult to the body, maybe a big infection, or maybe someone just decides they don't want to take their thyroid hormone replacement medications anymore and they become non-compliant, and then their body's metabolism slows down too much because they don't have their thyroid replacement medication on board anymore. So those are different causes. It's also very important to recognize the signs and symptoms of myxedema coma because it is life-threatening. So be sure that you are familiar with your signs and symptoms and your treatments, okay? So the opposite would be hyperthyroidism. Okay, so hyperthyroidism is the excessive synthesis and secretion of thyroid hormones. So this is when your thyroid gland is producing too much T3 and T4. So in hyperthyroidism, what you're going to see on their blood work laboratory results is their TSH levels going to be low and their T3, T4 levels are going to be high. And why is that? Well, think back to what I was explaining earlier. How does the thyroid know to make T3, T4? Well, the thyroid stimulating hormone that is released from the pituitary down to the thyroid says, we need more thyroid hormone, you need to make more T3, T4. And then that T3, T4 is produced, secreted by the thyroid gland, and it circulates in the bloodstream. Okay? So if your thyroid is making a lot of thyroid hormone, a lot of T3, a lot of T4, and that's circulating in your bloodstream, is your hypothalamus up in your brain going to recognize that it needs more thyroid stimulating hormone to be released? No. Because remember that hypothalamus looks to see where there are imbalances with hormones in the bloodstream. And if it sees, oh, there's adequate amounts of T3 and T4, we don't need TSH. We can just stay as we are. We don't need to produce anymore. There's plenty of T3 and T4 circulating. It's not going to give the signal to the pituitary to release the to release the TSH, right? So when you have high levels of T3, T4 circulating in the bloodstream, the TSH, or the thyroid stimulating hormone, is going to be low because the hypothalamus is recognizing there's plenty of hormone in the body right now. We don't need to stimulate more hormone production. Okay? So again, try to, help yourself to understand that mechanism, because once you do, it really makes a lot of sense as to why the blood work is the way it is. Okay? So TSH is going to be low and your T3 and T4 are going to be high. Again, this is more common in women. And causes include Graves' disease. So remember I talked earlier, Graves' disease is the autoimmune disease that attacks your thyroid gland, and it attaches to the receptors in the thyroid gland and causes the increased production of T3 and T4. So they have an increased production of thyroid hormones with Graves' disease. And one of the most classic clinical manifestations of Graves' disease is the exophthalmos. So that's when patients have the bulging eyeballs. So exophthalmos is bulging eyeballs, and that's very classic clinical manifestation of Graves' disease. Toxic multinodular goiter is another cause. So that means that there are nodules on the thyroid. So an enlarged thyroid has nodules, and the nodules are producing excessive secretion of the thyroid hormones. Okay. Toxic adenoma. So that would be if you had, like a cancer on your thyroid gland that was causing an increased release of thyroid hormones. Thyroiditis is inflammation. Sometimes if you get like a viral infection or viral inflammation of the thyroid, then that will cause you to produce more thyroid hormones. Excessive ingestion of thyroid hormone. So that's your levothyroxine. We just talked about that. The thyroid replacement hormone is levothyroxine. So if people are having too much of that, you're going to see signs and symptoms of hyperthyroidism. And also severe stress such as pregnancy. So pregnancy puts a lot of stress on the body. It really increases the metabolic demands of the body. So patients can end up with hyperthyroidism because of pregnancy. So clinical manifestations. So these patients are often very jittery, nervous, kind of like shaky at times, just very jittery, jumpy, emotionally hyper excitable, meaning that their emotions are kind of labile. They get excited very easily. Exophthalmos, so that's the Graves' disease clinical manifestation. That's the bulging eyes. Intolerance to heat, all right, tachycardia, high blood pressure. They have weight loss, facial flushing or flushed skin, sleep deprivation or insomnia. They have hypermotility of the GI tract, so they'll have things like diarrhea, and frequent mood swings. So you can kind of see here that these clinical manifestations are almost like completely opposite of those with hypothyroid. Because in hyperthyroidism, the body is sort of working at a much faster rate. Everything's going faster. They're very hyper. Things are, overactive, overproduction of hormones. And the body is just sort of like feeding off that excessive hormone production. So it's very overactive is really the only way to explain it. Gerontological considerations, so that's your elderly patients, again, are a little bit different. They tend to be very vague with their symptoms. They may just say that they feel a little bit fatigued, maybe anorexic, they've had weight loss, and they all of a sudden have a new atrial fibrillation. That could be caused because of their excessive secretion of thyroid hormones. So if patients come in with that and they have these vague symptoms, I know, where I work, one of our ICU doctors, I don't want to say always, but almost always will check an elderly patient's thyroid stimulating hormone level, the TSH level, to see if these, vague signs and symptoms that they came in with and this new AFib or this new arrhythmia that this patient has, if it could be caused because of the excessive secretion of hormones, the thyroid hormones. So this again is just your picture to help visualize what a patient with hypothyroidism, hyperthyroidism looks like. It's basically everything I mentioned on the previous slide, and you can see that they're hot all the time, intolerant to heat, and basically complete opposite of what the hypothyroidism patient looks like. There is a major complication of hyperthyroidism, and it is life-threatening if it is not treated. and it's called thyroid storm. Okay, you can see the other names for it listed there, thyrotoxicosis or thyrotoxic crisis. So they all mean the same thing. But basically, it is your extremely severe form of hyperthyroidism. So think again, what happens in hyperthyroidism? Your body, all of its organ systems, all of its, functions are very overactive. Everything's working really, really hard and just working harder than it has to. It's overactive. So with hyperthyroidism, their risk for this thyroid storm would be some sort of insult to the body. Again, kind of like I talked about before with hypothyroidism and the myxedema coma, it's some sort of insult to the body that causes this abrupt onset of severe hyperthyroidism. So a lot of times it's precipitated by stress. So that can be just emotional stress. It can also be physical stress to the body. Again, something like a big infection to the body that affects the body in ways that it kind of can't compensate very well and keep up with the metabolic demands because it's already exhibiting a very heightened or very fast metabolism. So your body basically becomes even more overactive, I guess is the best and most simplest way to put it. So your clinical manifestations, you're going to have very high fevers. So usually it's like, greater than 101. It can be as high as like 106, like really, really high fevers. Extreme tachycardia, so that's over 130 beats per minute. Hypertensive, so systolic hypertension, where their systolic blood pressure is going to be very elevated. Exaggerated symptoms of hyperthyroidism, so that's all the signs and symptoms I mentioned on the previous slides, just more exaggerated and more heightened and worse, more severe. Altered mental status, they could be restless, agitated, might have some confusion. Seizures are also possible. So our big thing is treating their cause of the thyroid storm and treating their signs and symptoms that are happening with it. So you want to reduce their body temperature. Remember, they're high fevers. You want to bring down their body temperature to normal. So sometimes these patients, if they have really high fevers, then you may have to put them on like a cooling blanket. So they are on this like cool mat that helps to bring their body temperature down. All right. So we can do things like that. We can give them medications to help reduce their fevers, but what is a medication that we would want to avoid giving them to reduce their fever? So try to think of it for a second. So what type of medication would I want to avoid when treating the fever in a hyperthyroid patient? Think back to that list of medications. So remember me mentioning aspirin. So you want to avoid aspirin in hyperthyroidism, especially a thyroid storm, because the aspirin increases the level of thyroid hormones. Okay? So if someone's in a thyroid storm and their thyroid hormones are already very elevated, their metabolism is really elevated, and their body is going through all of these, life-threatening changes and clinical manifestations, you do not want to give aspirin that's going to cause those thyroid hormones to go even higher. Okay? So reducing body temperature, but avoiding aspirin. Then reducing heart rate. So you can use things like beta blockers to help reduce the heart rate. So also remember earlier when I was talking about those list of medications, a beta blocker like propranolol can not only reduce your heart rate because it's a beta blocker, but it can also maybe help to bring down your thyroid hormones, right? Because that's one of the medications that lower your thyroid hormone production. So that might be a good one for this patient. Enhance oxygenation. So think of the metabolic demands on the body when someone is in this state. So if they have this really heightened metabolism and their body's compensating, they're really tachycardic, they're hypertensive, you're going to need to enhance their oxygenation so that their body is keeping up with the demands, right? So their oxygenation, you're oxygenating the rest of the body adequately and keeping up with those demands. And then you also want to administer your anti-thyroid medications, which I believe we'll be talking about on the next page. But there are certain medications that can be used to help bring down the thyroid hormone levels. All right, so this is, again, a life-threatening complication, and it is important that you know life-threatening complications. So your treatment and nursing care for hyperthyroidism. So your pharmacological treatment. So you have your radioactive iodine therapy. So radioactive iodine therapy is, like a pill form that patients can take that has radioactive iodine. And what happens is it concentrates in the thyroid, meaning it's all absorbed in the thyroid, and will damage the thyroid cells over time. All right, so the radioactive iodine therapy will help the iodine to concentrate in the thyroid, and over time will help to damage the cells so that it will have a decreased amount of thyroid hormone production. So radioactive iodine therapy can sometimes cause changes in the patient's taste. So like they may complain of like a metallic taste when they eat or drink something, whatever. It changes their way that they taste things, and that can happen. So that's something you want to educate patients about. It can also cause changes in your salivary glands as well. So metallic tastes is something like a side effect that's common with radioactive iodine therapy. And also with radioactive iodine therapy, you do not want to give this to pregnant women if they are hyperthyroid, maybe because of their pregnancy. This is not a treatment that you would choose for them because the radioactive iodine can cross the placenta and harm the unborn fetus. So those are some side notes, sort of just to keep in the back of your mind about pharmacological therapy with radioactive iodine. There are also anti-thyroid medications. So two of them listed here, propylthiouracil or PTU, and methimazole or tapazole, the other name. So these two medications help to inhibit the incorporation of iodine into T3 and T4. So basically it helps, remember iodine helps to produce the T3, T4. Well, those two medications, the antithyroid medications, help to sort of block that mechanism. All right. So the iodine will not be able to help, the thyroid gland to secrete T3 and T4. It blocks that mechanism. So these medications are very strong. They can be very potent on the body. One of them can be given during pregnancy, and that is the PTU, the propylthiouracil. That one is considered safe during pregnancy if someone is hyperthyroid. So both of these medications can cause problems with basically your bone marrow. So you can end up with things like agranulocytosis. So if someone ends up with agranulocytosis, they're going to be at high risk for things like infection. So you want to be monitoring patients' blood work while they're receiving this medication. Because if they're having problems with their immune system related to this therapy, then this therapy might not be adequate for them. They may need to be weaned off these medications and switch to another therapy. They can also be toxic to the liver. So it's important to monitor the liver enzymes, so the liver function tests, make sure that their liver is not becoming toxic from these medications. So those are some important things that you should know about these two anti-thyroid medications. There are also medications called sodium or potassium iodide solutions. So the saturated solution of potassium iodide, or the SSKI, is a medication that can be used to suppress the thyroid function before somebody goes for like a thyroidectomy. So it helps to suppress the thyroid function. It's given usually a few weeks before their thyroid surgery. And another benefit to these medications is it also helps to decrease or reduce the vascularity of the thyroid gland. So remember back in the beginning, I mentioned the thyroid gland is very vascular. So very, very high risk for bleeding with surgical procedures. So these medications like the saturated solution of potassium iodide, SSKI, are given to help reduce the function of the thyroid and help reduce the vascularity of the thyroid before surgery to help reduce the risk of hemorrhaging or bleeding during surgery. Dexamethasone, so sometimes steroids may have to be given just because of, the stress and increased metabolism that the body is exhibiting. They may need some dexamethasone or something to help sort of support the corticosteroids in your body when your body is under this amount of stress. And your beta blocking agents, so that's your propranolol. I mentioned that earlier. Propranolol can help with the symptoms of hyperthyroidism, because remember, tachycardia, hypertension are some of the symptoms. So it can help to decrease your symptoms and also help to decrease the T3, T4 production. So those are your medications that I want you to be familiar with. And then another treatment would be your surgical treatment. So patients can have either a total thyroidectomy, meaning that they remove the entire thyroid gland. And that's more common in patients who have like a thyroid cancer or something. But their thyroid gland will be removed totally. And then there's also something called a subtotal thyroidectomy, where they only remove some of the thyroid gland, but leave enough behind that hopefully it can still produce adequate amounts of thyroid hormone. Sometimes after these surgical treatments, especially if it's a total thyroidectomy, if they have no thyroid at all, then they're going to need the thyroid replacement hormone for the rest of their life, right? Because they'll no longer have a thyroid to produce any thyroid hormone. So that's something to keep in mind. If they've had a total thyroidectomy, they'll need some thyroid replacement hormone for the rest of their lives. And I do have a little page after this to discuss more thyroidectomy nursing care. But I want to talk about nursing care about hyperthyroidism quickly. So limit activities to quiet ones. So why would that be? Because these patients are oftentimes very irritable, they're nervous, they're jittery, they're hyperexcitable. So you want them to kind of have a nice calm environment, just relaxing. You don't want, like if they're, in the hospital for problems with their hyperthyroidism, you don't want them having visitors all the time and stimulating them all the time. You want them to just rest and relax. You need their body to be calm, right? Provide frequent rest periods, and that's just because of the increased metabolism. So let their body rest so they can keep up with the metabolic demand. Maintain a cool room temperature because they are intolerant to heat. Light clothing because of the same reason, intolerant to heat. Avoid stimulants such as coffee, because what does caffeine and coffee, those sort of things do? Increases your heart rate and your blood pressure and everything, and these patients already have that. So you don't want them to increase their vital signs even more. So try to avoid stimulants. And then use a calm, unhurried manner when caring for the patient. And that's, again, just because they tend to be more nervous, hyperexcitable, a little bit like on edge. So you want to just be kind of calm, don't seem rushed around the patient, and just sort of like take your time and don't, I guess, like feed in to their stressful feeling that they sometimes can have. So your thyroidectomy patient. So this is important to know. So preoperative goals, education, is educating them about the procedure that they're going to undergo. So you're going to explain that whether it be a subtotal thyroidectomy, they're going to have some of their thyroid removed, or a total thyroidectomy, they'll have the whole thing removed. And what are they going to expect after surgery? Well, post-op care is going to include meticulous assessment on their airway. So you want to keep an eye on their airway patency, because think of where the thyroid is. It's anterior to the trachea. So if they have any degree of swelling after the surgery, or if they have bleeding and a hematoma develops and it's pushing on the trachea, they're at risk for airway compromise. So it's very important to keep a tracheostomy at the bedside, tracheostomy set. Okay, so if the patient's airway were to become occluded due to, edema or something along those lines, the physician would have to emergently place a tracheostomy at the bedside. Monitor for bleeding, because why? The thyroid's very vascular, so you want to watch for signs and symptoms of bleeding or hematoma formation. So that means check all around their neck, kind of like up over their shoulders too, because if they're bleeding, the blood can collect like under, oops, sorry about that, 1 second. Sorry about my dogs barking in the background, but I think I was talking about the bleeding. So you want to assess like not only just their incision site, but in their neck and over their shoulders, because when they are positioned in the bed in their semi-Fowler's position, some of the blood can sort of migrate, to the top of their shoulders or over their trap, and develop like hematomas. So you want to look for like bruising anywhere up in that neck region. Pain management, simply because of their surgery that they had, making sure that their pain is controlled. Position, the best is semi-Fowler's, simply because you want to assist with their airway. You want them to be in the most adequate position that they can to maintain a patent airway, and support their head and neck to prevent hyperextension of the suture line. And that simply means don't let their head go back at all so that they're like stretching the incision line. You want to keep it neutral and just have it supported, with a pillow. And then assess the patient's voice. So again, think of where the thyroid gland is. It's right below the larynx. So you want to assess that their voice still works okay, but you also want to discourage too much talking. You want them to rest their voice as well. And then also monitor calcium levels. So in the thyroid gland, there are 4 little tiny glands called the parathyroid glands. And those parathyroid glands help to regulate calcium in the body. So if those glands are injured during the surgery, or they are completely removed, if it's total thyroidectomy, then they are at risk for hypocalcemia. So low calcium levels. And what you would see with low calcium levels are tetany, so that's like muscle twitching, and you would need to treat them with calcium replacement. So that would be like your calcium gluconate or your calcium chloride. So this stuff is very important to know for thyroidectomy patients. This slide here helps to just sort of recap the differences between hypothyroidism and hyperthyroidism. So kind of your common signs and symptoms are listed there, and your treatments and your nursing care that is important. So if you guide your studying based off of this recap slide, it will be a very good start. If you can sort of recall all this information yourself and understand why these things happen with each, disorder, then you'll be in good shape for studying for the exam. And then your parathyroid disorders. So this is just very brief. I just want you to know the difference because it goes hand in hand with thyroid because of how the parathyroid glands basically sit within the thyroid gland. And if there's manipulation of the thyroid gland because of surgery, then you could possibly see changes in their parathyroid gland. So the parathyroid gland helps to control the level of calcium in the body with a hormone called the parathormone. So in hypoparathyroidism, the causes would be removal of the thyroid gland. So this is where the parathyroids have been damaged and they no longer can help to regulate the amount of calcium in the blood. So patients will end up with low calcium. So signs and symptoms, they'll have neuromuscular system irritability, tetany, positive Chauvet's sign, and positive Trousseau's sign. All right, if you haven't seen a little video of those two, like hypocalcemia signs and symptoms, you should YouTube them. If I were doing this lecture in class, I would show you here because it's on my screen and show you the difference between the two signs. All right, so the difference between the two is that the Chauvet's sign is going to be when you tap a patient like on their jaw, basically, like in front of their ear, right along their jawline. Their facial muscles will sort of twitch when their calcium levels are low. And then your Trousseau's sign is going to be when you apply pressure to like the arm, and the most common way to do it would be like putting a blood pressure cuff around somebody's arm, and you inflate the blood pressure cuff to squeeze the arm, and you leave it there for a couple minutes. And what you'll start to see is that the hand and the fingers on that affected side will sort of like contract or stiffen up, and you'll see them sort of contract inwards. So again, if you haven't seen that before, you don't know, what I'm really talking about or how I'm explaining it, just YouTube it and you can see the difference between the two signs. So that is caused by low calcium levels. So your goal is to increase the calcium to 9 to 10. You want to give calcium supplements and also vitamin D supplements because vitamin D helps to absorb calcium from the gut. So you kind of give those hand in hand to help the absorption. So nursing care would be calm, quiet environment, minimal stimulation, and that's because of the neuromuscular system irritability. Monitor their cardiac status, so you want to have them on a telemetry, on a cardiac monitor for their risk of dysrhythmias with abnormal calcium levels. For their diet, you want a high calcium, low phosphorus diet, because when you have a high, or I should say the opposite, when I have a low calcium in my blood, you're going to have a high phosphorus level. So they're going to be opposite. So when you're having someone with hypoparathyroidism, you increase their calcium intake and you want to keep their phosphorus intake low, okay? And you monitor for your signs and symptoms of hypocalcemia. And then the opposite of that is your hyperparathyroidism. So causes are overproduction of parathormone by the parathyroid gland. And this basically causes the calcium level in the blood to be way too high. So signs and symptoms would be muscle weakness, hypoactive DTRs or deep tendon reflexes, nausea, vomiting, constipation, anorexia, high blood pressure, and also a big risk for cardiac dysrhythmias. So if calcium levels become very high, like in a hypercalcemic crisis when their calcium level is greater than 13, then they're at very high risk for cardiac dysrhythmias and sudden cardiac death. So it's important to monitor their calcium levels. So treatment would be parathyroidectomy, so remove the glands that are causing too much of the parathormone to be produced. And nursing care would be monitoring your calcium levels, encourage PO fluid intake, because when patients have high amounts of calcium, they're at risk for renal calculi or kidney stones. So you want to encourage their PO fluid intake to help sort of like flush out their system and keep their calcium from building up in the kidneys, causing kidney stones. You want to avoid foods that are high in calcium. I mentioned the hypercalcemic crisis, so if the levels go above 13, you're going to be concerned for severe cardiac dysrhythmias, and monitor for post-op complications after they have gone for their parathyroidectomy. You want to watch for signs and symptoms of hypocalcemia and your tetany, Chauvet-Steck's sign, and Trousseau's sign. All right, so that's sort of an overview, like difference between the two, but sort of the main points that I want you to get is that when patients have thyroidectomies, they've had surgery on their thyroids, they're at risk for the hypoparathyroidism, which would result in low calcium levels. And how would you recognize that? Practice questions. A patient is admitted with thyroid storm. Which signs and symptoms are associated with this condition? Select all. So it's going to be A, B, D, and E. So remember, thyroid storm is associated with hyperthyroidism, so metabolism is heightened. Everything's accelerated, everything's faster, everything is more severe. So they're going to have the high temps, high heart rates, they're going to be agitated, restless, confused. They're going to have hypermotility of the bowels, meaning more frequently having diarrhea. So it's your severe hyperthyroidism clinical manifestations. A patient has an extremely elevated T3 and T4 level. Which of the following signs and symptoms will be present with this condition? Select all. So remember, elevated T3 and T4 level is your hyperthyroidism. So they're going to have weight loss, they're going to be hyperexcitable, diarrhea, and insomnia, sleep disturbances. Thyroidism is having 6 out of 10 pain in their right hip due to recent hip surgery. Which of the following medications should be avoided in this patient? Select all. So remember, hypothyroidism, your metabolism is slow. Your body has a hard time metabolizing some of these stronger medications. So what would you want to avoid? Things like fentanyl, morphine, Dilaudid. The Tylenol and ibuprofen would be okay because those are mild pain medications. A patient is receiving radioactive iodine treatment for hyperthyroidism. What will you include in your patient education about this type of treatment? So remember, they tend to have the metallic taste in their mouths. They have taste changes on this medication. So taste changes and swollen salivary glands. A nurse is caring for a patient with hyperthyroidism. Which of the following nursing interventions are appropriate? Select all. So, think of your signs and symptoms of hyperthyroidism. So, patients will sometimes have the bulging eyes, exophthalmos if they have Graves' disease. So their eyes may be a little bit irritated, dry, so they may need eye drops, right? So you have that. Provide several small, well-balanced meals because think of their high metabolism that their body's trying to keep up with. And their body with this high metabolism is sort of breaking down their nutrition so fast that their body is still depleted of nutrients that it needs. So they're actually malnourished. So the best way to sort of feed these patients is give them like that high calorie, high protein, high carb. You really want them to have like good, substantial snacks and meals throughout the day to help prevent their nutritional deficits. Provide rest periods, again, just because they're hyperexcitable, their body is very accelerated and just overactive, and you need them to kind of calm down, have that calm environment. When you're caring for them, you try not to be rushed, you take your time so that they do not feel more stressed and put more stress on their already elevated metabolism. And then weigh the patient daily because they have the risk for weight loss. All right, so that is it with the thyroid disorders. Again, if you follow the recap slides, those should really help to guide your studying. And as long as you can look at those slides and really understand why does this happen with hypothyroidism or why does this happen with hyperthyroidism, then you'll be able to really understand the concept and the thyroid disorders. Okay, so that goes for the different treatments. Why does it help the thyroid disorder? Why are we giving thyroid replacement hormone for hypothyroidism? Why are we giving medications to help slow down the thyroid hormone production in hyperthyroidism? And what is my nursing care for each? So not only what is my nursing care for each, but why? How does it help the patient who has whatever thyroid disorder it is or whatever parathyroid disorder it is? So why is it significant? So I try to say that because with our exams, we don't just want you to know the facts and that, providing, what can I use as an example? I guess providing patient education in regards to taking their thyroid replacement hormone as ordered for hypothyroidism. You don't just want them to know, okay, you have to take this as it's ordered. You want to know why do they have to take it specifically as it's ordered? Well, because it has effects of insomnia, so you want them to take it in the morning so they'll have the best effect and it won't keep them up at night. It needs to be on an empty stomach because of the malabsorption if it's taken with anything else. And the full glass of water because if it stays in your esophagus, it's going to end up causing esophageal problems. All right, so don't only just associate levothyroxine with hypothyroidism, really understand why. All right, so I hope that helps you. I know that this concept can be a little bit confusing because it sounds like, blood work is opposite when it should be the other way. A lot of times students have some confusion with that. So if you feel that way, please just reach out to me and let me know. You can email me with whatever questions you have. I always try to get back to everybody as soon as I can so that I can help your learning, and especially in times when you're studying for an exam. So if you have any questions, reach out to me. And otherwise, I will be seeing you soon. I hope that you have a lovely summer break.